Good morning and welcome to session 3 of our 2024 ACR Annual Educational Workshop. I'm Juliet Wilkins. I'm the Training and Policy Manager, and you will be hearing quite a bit from me today. Here is our agenda for this morning. I will be starting us out by talking about 2024 data collection changes and also looking ahead a little bit to 2025. And then I will be going through a presentation on navigating grade, because I know coding grade is something that we still find challenging ever since the 2018 changes to how we code grade. And then finally, Michelle Lenzen, our QA manager, will be presenting on ACR quality assurance projects and updates. And just a reminder, if you attend all 4 sessions of our webinars, you will be receiving 8 CE hours, and 3 of those CE hours will be category A. So you should have received a tracking sheet so that you can keep track of which sessions you attend and how many of those 8 CE hours you earn. And after session 4, then I will be sending out the CE certificate to all of you who attended our workshop. And I just also wanted to mention that we are going to be posting a link to the evaluation for today's presentations in our chat, and we do encourage you to fill those out. That feedback is really valuable to us as we plan future educational opportunities, because we want to make sure that what we present is what you need to do your jobs. We know that our hospital registries are the ones who are working on the ground, working very hard to get us our cases, and we want to make sure to give you all the resources and support that we can. So that is all the introduction that I have for this morning. And give me just a moment and I will get started with our first presentation of the day. All right, so you should be seeing my presentation on 2024 data collection changes. And this is not meant to be all-inclusive, but I do want to hit some of the highlights of what is new and different as you start abstracting 2024 cases. The objectives for this presentation are: I will be explaining data collection changes applicable to 2024 and forward cases. I will be describing the appropriate references that you're going to use once you start abstracting for 2024. And I will also be providing some information about which required site-specific data items we will be collecting for 2024 here at the ACR. And then finally, we're going to look ahead and start to talk about what is happening for 2025. Data collection always moves on. The slide that you should be seeing on the screen should have all of the 2024 ACR documents that you will be using to abstract your 2024 cases. And those have been posted since May. So they are available to you on our ACR website. Remember that it's not just the ACR coding handbook, which includes the 2024 version of STORE and our updated ACR supplements, but we also have other documents related to our ACR manual that will be useful to you as you abstract for 2024. So for instance, we have an appendix that talks about NACER recommended abbreviations that you can use while you're abstracting if you need to abbreviate your text. Those are the standard in our cancer registry world, as you know. And then we also have race and nationality descriptions for you. We have documents that list what our required data items are here at the ACR for 2024. And we also have a list of required site-specific data items. And finally, I wanted to call your attention to the ACR texting table that we have provided. We started that last year, and when you look at those tables, you'll see a column of what elements are required for each of the text fields. And to meet our minimum standards, all of those required elements need to be in your texting because they are required. We also have an additional column that gives you our recommendations for what we would like to see in your text, but the requirements are the requirements, and that's what you have to have in your text. You'll also see, if you compare those ACR texting tables to our texting supplements in the ACR supplements of our manual, that they are the same. So we've tried to bring everything across from the texting supplements to the texting tables, but the texting tables are a really good quick reference for you as you are considering what to include or not include in your texting. Here are your 2024 manuals. As we know, AJCC is rolling out their version 9 protocols, and they just recently released AJCC online staging, so that is available as well. The sites that were updated for 2024 are mostly neuroendocrine tumors, as you can see, and I'm not going to spend much time on that right now because we only require SEER summary staging here at the ACR, but there are some new rollouts from AJCC, and if you are a college facility, you are likely still required to AJCC stage. So those are available to you. There's the site-specific data item manual. The latest is version 3.1, and you always want to make sure that you're using the correct version of all of these manuals as you are coding your cases. Same thing with SEER summary stage. The latest is version 3.1. The grade manual, same thing, but we do have an updated version. There are new updates to the ICD-0 3.2 histology codes and behaviors, and that is all based on the WHO 5th edition. As the WHO 5th edition classification of diseases gets updated, then the ICD-0 gets updated as well. And at this point, from everything that I've read, they are not going to be putting out a PDF version of ICD-0 3.2. They're really focusing on the eventual release of ICD-0 4. So for 2024 cases, you're still going to be using the spreadsheets just like you're used to, but make sure that you are referencing those ICD-0 3.2 spreadsheets as necessary to code your histologies correctly. And then, of course, the solid tumor rules, there are updates for 2024, and now we even have updates. They released the other site rules in 2023. So for 2024, you should be coding all of your cases using the solid tumor rules. And then, of course, there's the 2024 STOR manual, and we use that as the foundation of our 2024 ACR manual. And all of those should be available for you as of right now once you're ready to code an abstract for 2024. So on our ACR website, I've just taken a screenshot there for you. We have our 2024 manual uploaded to the website under Cancer Registrar Resources. There's a tab for Arizona Cancer Registry Coding Handbook. And under that, you will find all of these resources that I have been referring to. So they are uploaded, they are available, and we also have archive versions of 2023 and 2022 as well, if that's still what you are abstracting. That's how you access our manual. And if you are abstracting for Arizona, you should be using the ACR manual, including our ACR supplements, the abstracting your cases. So what is new and different for 2024? And again, this is not an exhaustive list. You should be looking through the implementation guidelines that NACER puts out. You should be looking at the change logs for any of the SEER manuals, like the summary stage manual and the solid tumor rules. And you should be looking at STOR's section where STOR walks you through changes for 2024 as well. But I've just attempted to give you most of the highlights. So what are the new data items? You should see them here on this slide. The only one that the ACR is adopting is a derived data item called Derived Summary Grade 2018. And I'll be talking about that a little bit more once I get into my presentation on grade. But that is a field that will be derived here at the central registry. You're not going to be coding that field, but it is derived based on your codes in those grade fields. So grade clinical, grade pathological, grade post-therapy, that's what's going to tell the algorithm what to code for the derived summary grade field. Here are some retired data items for 2024, and most of these we here at the ACR have not required for years, but they're finally retiring them from STOR. So those are going away as of 2024, and that will help you to update your layout and know what you shouldn't be coding. Here are some more retired data items. You'll notice that some of them have to do with fields that have just been renamed. So for instance, maiden name back in 2021 became name, birth, surname. We should have been coding that for the last couple of years. So I'm not going to spend too much time here because most of these are changes that have happened in the past that we have already reviewed in these updates presentations. We do have some new revised surgical codes, and they're just going to keep revising those surgical codes to the new 4-digit surgical codes where you have your A or your B to indicate whether that is a new code or not. And that's expanded the range of surgical codes that we are able to use. And I did a presentation last year on why they went to these new surgical codes, and that is still available up on our Flossy site for you. So if you want more information about that, we do have that presentation for you as well. But this year they really focused on revising surgery codes for colon, pancreas, lung, breast, and thyroid. And you're going to find the correct codes in Appendix A of the STOR manual. You should be going there to look at what the new surgery codes are and coding surgeries according to the newly revised surgical codes that we have available. So here's an example from the thyroid surgery codes, which have been revised for 2024 diagnosis and forward. You'll see that it's that alphanumeric code like we've been used to since they started releasing them, that it's either an A or a B, and in this case, it's a B, followed by the correct surgical code. It still goes in hierarchical order. So the lower the number, the less intensive the surgical procedure is. More extensive surgeries get higher numbered codes. And so we should be used to this by now, but I just thought I'd give you an example of what those new surgical codes look like. P16, let's talk about that really briefly. We do require P16, this NACER data item, and I have the data item number up there for you. It's 3956. We have been requiring it for cervix, which was added in 2022, and anus, which was added in 2023 as a required data item. And we are adding vulva for 2024, and that's in keeping with how STOR is treating that data item. Just be aware that we do have a new site to add where you are going to be required to code P16 value as that is available. What about manual updates? I mentioned ICD-0 3.2, and for 2024, there haven't been many major changes. Most of the changes involve new related terms for existing codes. The 2024 update includes 5 new ICD-0 codes or terms. 4 of them are reportable and 1 of them is not. And 1 histology has changed behavior and it is now reportable. And as you see on my slide, the focus is really on revised behavior codes for urinary and male genital tumors for 2024. And that's related to those WHO 5th edition classification books that keep rolling out. And as I mentioned, they don't plan to publish a print or a PDF version, so you have to be using these spreadsheets. And you have to be reading through the guidelines to make sure that you are coding accurately. Here are some of our new histologies, and these are the reportable histologies. You'll note that the behavior code is 2 or 3, and tumors with a behavior of 2 and 3 are reportable. You'll see that, as I said, most of them have to do with urothelial tumors. So they have some new codes for non-invasive papillary urothelial carcinomas, And they have some new codes related to genetic tumor testing. Like you'll see 8510/3 is for S-mark B1 deficient medullary like renal cell carcinoma. And make sure that all of the terms that are listed under the histology code are listed in the pathology report before you code to these new codes. So it should say S-mark B1 deficient medullary like renal cell carcinoma for you to use that code. Some of them are related to male genital tumors. You'll see that the new 9061/2 code, 9070/2, those are all related to male genital tumors. Make sure that you are using those codes appropriately. We do recommend reviewing all the new ICD-0 3.2 terms for 2024 that are now considered malignant. And make note that as you're looking through the ICD-0 3.2 updates table, that we follow the column indicated with required NPCR. So if it is a required NPCR histology, then the ACR is going to likely require that as well. There's one behavior change, and that is the histology 9104/3, which is placental type trophoblastic tumor of the testes. The behavior changed from 1 to /3, and that is now reportable for cases diagnosed January 1st, 2024 forward for testes only. And then the other new code that I wanted to draw your attention to is the HPV-associated squamous cell carcinoma, which is now valid for primary sites C60 and C63 beginning 1/1/2024. And that P16 test can be used to code the HPV-associated and HPV-independent histologies. So those are your new histology codes. And let's talk briefly about the solid tumor rules. You're going to find a list of revisions at the SEER website, seer.cancer.gov/tools/solid tumor, and make sure that you look at those revisions and that you familiarize yourself with what is new. So there are some new terms and definitions and histologies that are added to the other sites modules. Those are going to be in keeping with the updates made to the ICD-0 3.2 histology tables. And it's a good idea to familiarize yourself with those new histologies as well. I just wanted to highlight a couple of the changes that you'll see on my slide that have to do with coding breast cases. And some of these changes have to do with the cancer path chart project that I know Michelle is going to be talking about a little bit later in her presentation. But for instance, pure in situ lobular carcinoma with other types of in situ carcinoma has been deemed biologically impossible. Those cancer path chart experts have taken a look at that and said that that is just very, very unlikely to happen based on the cell type that they were looking at. So we have some new histology rules related to those cancer path chart decisions. For instance, Rule H8 and H9 will tell you what to do if you are coding those cases of in situ lobular carcinoma with other types of in situ carcinoma for pre-2024 versus 2024 and forward. So you're going to want to make sure that you are using your solid tumor rules to code your cases, or you will get that histology wrong. And then those cancer path chart experts for breast histologies also determined that certain histologies with individual ICD-0 codes are to be considered synonyms for the not otherwise specified terms for cases diagnosed January 2024 forward. And they mark them with that double cross symbol. I've got an example highlighted on my slide for you that metaplastic carcinoma spindle cell type or spindle cell carcinoma is now considered a synonym for metaplastic carcinoma NOS. It used to be a subtype or variant, which means that it used to have its own histology code, but now it is considered a synonym. So 2024 forward, we will use that metaplastic carcinoma NOS code. And that's just one example, but you'll see some other examples throughout the solid tumor rules as you look at the updates for 2024. There are some new tables added to the other sites rules. I mentioned that those were released back in 2023. Well, now they've added 3 more tables, one to cover histologies for liver and intrahepatic bile ducts, one to cover thymus histologies, and then one to cover penis and scrotum histologies based on those WHO 5th edition updates. So be aware that those tables exist, use them appropriately to code your cases. Another new data item that I want to spend just a couple of minutes talking about is brain primary tumor location. And you see the NACER data item number there. This is to further specify, because we know how complex the midbrain anatomy can be, and it was deemed important to be able to locate where in the midbrain those tumors are occurring. So we do have a new site-specific data item for brain cases, and you'll see that I've got the list of codes up there. I've tried to label this picture of the brain with where all of those sites are. So for instance, a code of 1 would be for pons, and you should see my cursor on the screen, and I've got a little line from pons to where that is located in the midbrain. And then 2 would be a code for a other than pons, which includes the basis peduncle, the cerebral peduncle, the choroid plexus, and the fourth ventricle. So you can see those labeled on my slide as well, as close as I could come to where those are in the brain. The cerebral peduncles are located just above the midbrain, as you see on that slide. And then the fourth ventricle is actually right where the hindbrain is connected to the midbrain. You can see that in red, that little red highlighted area on my slide. And then 8 would be, we have the infratentorial brain, and that should be labeled for you as well on here. There were some really good slides that were put out by SEER as well to talk about brain anatomy. So use all of your resources to figure out where all of these locations are. It does get pretty cluttered in the midbrain, but we should be coding this data item appropriately. And then you see the midbrain labeled on my slide, and we've got the olive and the pyramid. So the olive and the pyramid are right here next to each other, just above the medulla oblongata on my slide. And that's just to give you a sense of how complex this area is and to help to decide what code is the most appropriate to use. And then obviously we still have our 8, which is not applicable, and 9, which is brainstem NOS, when we don't have a specific region of the midbrain or brainstem to be able to code to, or if we just don't know what the site is. And then we leave it blank for pre-2024 cases. That's what you're supposed to be doing with this data item. Or if the primary site is not C71.7, then you would expect that this site-specific data item would be blank. I mentioned the AJCC 9th edition, and I'll just try to speak right into my microphone, so hopefully you can hear me a little better. There's not going to be a single edition of the AJCC. They're breaking it up as they roll out the 9th edition updates. AJCC is not required by the ACR, so you can continue to not code that for 2024, but just be aware of the new 2024 subsites that were released. And it's really based on the needs of clinical care and the surveillance community. And it also ties to the WHO Blue Book cycles as the WHO 5th edition is rolled out. And they do now have an electronic platform for AJCC, so that's nice because that can be quickly adopted into your software. So very briefly, I just want to look ahead to 2025 and what some of the upcoming changes are going to be. Here are some potential updates. They have started releasing the 2025 store manual and some of the associated manuals. So it's good to talk about these. The NACER implementation guidelines for 2025 were released back in July of 2024, and they've already updated them in August. They're continuing to do these rolling updates. So it's not like it used to be where you would just have one update for a coding year and you wouldn't have to worry about any changes being made throughout the year. But they are continuing to make changes throughout the year. So we will keep you updated as we find out that there have been changes made to any of these manuals. There's going to be a new site-specific data item for lung, and that is collecting PD-L1. That's that tumor marker that can be helpful in further characterizing lung cases and determining what treatment those patients should have. So expect to see at least one new site-specific data item. Expect that there may be another site-specific data item for post-transplant lymphoproliferative disorders. And there are going to be some major revisions to the hematopoietic manual. And I know that that may not be for 2025, but certainly within the next couple of years, we're going to see some changes to that HP manual to bring it more in line with the solid tumor manual. So I'm sure there's going to be a lot more information about that as that revised HP manual rolls out. But for right now, for 2024, we're continuing to use the hematopoietic manual as we know it. And then there's also going to be some new fields to help with data collection from pathology labs and uploads to the virtual pooled registry. I know Dana talked a little bit about that and how our data is going to that virtual pooled registry. And then, of course, there's going to be some changes because of the cancer path chart site histology validation list as they revise that. So I know Michelle will talk more about that. I'm not going to get into it too much, but I just wanted to make you aware. And then there are going to be a few new AJCC 9th edition modules. They're expecting to release 3 or 4 of those every year, and it looks like the next sites that they're going to revise are thymus, lung, mesothelioma, and nasopharynx. So we can expect to see that. Obviously, no crystal ball here, but that's a heads up on where data collection is going beyond 2024. Let's see, are there, well, we'll go ahead and cover any questions at the end of today's session. So just continue to put those questions in the Q&A chat, and we will get to those in our Q&A period. So that is the first presentation of the day on 2024 data collection changes. You can always email me with your questions as well if they come up after the session. I will very quickly switch my presentations and we'll talk about grade. All right, I am back and you should be seeing my grade presentation on your screens now. Our second session of today's workshop is talking about navigating grade. I did put out a smaller article about grade in our ACR updates newsletter a few months ago, but I figured this would be a good chance to go into a little more detail on grade as well. So I'm going to be covering the concept of tumor grade as it relates to cancer coding. I'm going to be talking about the differences between clinical, pathologic, and post-therapy grades so that we know how to code the correct grade for the point in that patient's cancer journey that we are assessing grade. And then I'm going to talk about how the grade manual is organized and how we can better use it as a resource when we are coding grade. And then I'll be working through a few sample 2024 cases and coding the appropriate grade for a variety of primary sites. Let's dive in. So what is tumor grade and why does it matter? I've got a definition there up on the screen, but basically tumor grade covers how normal or abnormal those cancer cells look under the microscope. The closer those tumor cells look to, quote, normal tissue for that particular region of the body, the better prognosis the patient usually has. Tumors that are less like the cell type that they originated from are going to tend to be more aggressive and require different treatment strategies in order to manage that patient's cancer. Pathologists can describe differentiation using either a 2-grade system, which would be low or high grade, a 3-grade system, which is what we're used to with grade 1 or well differentiated, grade 2 or moderately differentiated, or grade 3 or poorly differentiated, or pathologists can use a 4-grade system, where grade 1 is well differentiated, grade 2 is moderately differentiated, grade 3 is poorly differentiated, and grade 4 is undifferentiated. And the grade manual has some more specifics about that, but that's the background. Oh. All right, can everybody hear me now? Okay, perfect. Sorry about that. Testing our audio over here. So basically, I just went over the objectives, which hopefully you saw on the screen. And now I'm talking about grade as a concept. What is it and why does it matter? Besides the definition that I've got on my slide, grade basically is how normal or abnormal those cancer cells look under the microscope. The closer that those cancer cells resemble the original cell type that they originated from, the better prognosis those patients usually have. And the more abnormal those cells look under the microscope, the more aggressive those tumors usually are. And the different treatment may be required to manage that patient's cancer journey. Pathologists can describe differentiation or grade using a 2-grade system, which would be low or high grade, a 3-grade system where 1 is well differentiated, 2 is moderately differentiated, and 3 is poorly differentiated, or pathologists can use a 4-grade system where grade 1 is well differentiated, grade 2 is moderately differentiated, grade 3 is poorly differentiated, and grade 4 is undifferentiated. And again, that's talking about how closely those tumor cells resemble normal cells for that particular part of the body. And the grade manual has some more specifics about that. For 2024 cases, the ACR requires grade clinical and grade pathological. Grade post-therapy path and grade post-therapy clinical aren't required, but they should be transmitted if they're coded. For instance, again, if you're at a COC accredited facility, you are coding those anyway, so they should be included with your NACER data submissions. I did talk earlier about derived summary grade, which is our new field for 2024. And that derived summary grade field is only going to be as good as how you are coding grade clinical, pathological, and possibly post-therapy, because there's an algorithm with that new data item that's going to help us derive grade here at the central registry. But it's all based on
how you code grade in your abstracts. And grade is assessed at multiple points along the patient's cancer journey. This is very similar to those timing periods for AJCC stage, but it's not identical. So we're talking about grade, and the grade manual defines clinical, pathological, and post-therapy grade. Clinical grade, of course, is based on tissue collected prior to any definitive treatment. Systemic treatment, for instance, can alter that tumor grade as the tumor hopefully responds to that systemic treatment. Radiation can alter the grade of a tumor. So we really want to code any tissue that has been evaluated prior to the initiation of treatment in clinical grade. That includes your biopsies. That includes any procedures that count as diagnostic but don't meet the criteria for surgical resection based on the primary site. So for instance, prostate is an example of that, where your TURPs wouldn't qualify for grade pathological. So you really need to use the appropriate section of the grade manual when you're coding grade, because that will tell you which procedures qualify for pathological grade. And if it's prior to any of those procedures, then we would code it in clinical grade. Grade pathological includes all of the information that was collected during the clinical workup, but it also includes that pathology report from a definitive surgical procedure, which is defined based on the primary site. For instance, again, I have that urinary bladder example up there for you. You would code grade pathological for patients who have had a cystectomy or a nephroureterectomy and include that information in grade pathological. Then there's post-therapy grade, which is the highest grade from tissue assessed after the administration of neoadjuvant radiation or systemic therapy. And that grade can determine the need for further treatment or not. And then that's split into post-therapy clinical, when they've done some more biopsies after treatment, for instance, to see how that tumor has responded, or post-therapy pathological, which would be for tumor that is resected after neoadjuvant therapy. Some histology terms include the word grade. We can't necessarily assume that we can use that term to code the grade data items. I've given you an example up there: papillary neoplasm, pancreatobiliary type with high-grade intraepithelial neoplasia. That high grade isn't actually talking about tumor grade the way that we're understanding tumor grade. That's a term that is used as part of the histology. And I know Jim Hofferkamp has had some webinars where he's gone into some detail on that too. But just keep that in the back of your mind as well. We're looking for grade as the pathologist defines it on the pathology report, not necessarily grade that might be a term that's used in some of these new histologies. Here's an example of grade. Some grading systems just evaluate the pattern or architecture of the tumor on those pathology slides, and Gleason score for prostate is a great example of that. This is what pathologists use when they're determining those Gleason patterns, and I thought it was kind of neat to see it up there on an image as that tumor devolves from small uniform glands that resemble normal prostate tissue all the way to only occasional gland formation at the bottom, which would be your Gleason score of 5. And you can see on that slide, as we move from well differentiated down to poorly differentiated for prostate cases, but we base grade for prostate on those Gleason scores. Some other grading systems just use a nuclear grade, such as size, such as degree of irregularity or mitotic activity, to code grade. Most grading systems use a combination of that pattern, like Gleason, cytologic, and nuclear features. So for instance, Nottingham grade for breast cancer is a grading system that uses a combination of pattern, cytologic, and nuclear features to code the grade for that particular site. So it's really going to depend on which site you are abstracting, how that grade is going to be assessed, and how you are going to code that grade. Part of the reason why we talk about grades so much is it really does determine treatment. So I've given you an example from the 2024 NCCN guidelines for neuroendocrine tumors, and you can see that there is a difference in the treatment recommendations for first-line therapy if that is a low-grade or a typical carcinoid versus an intermediate grade or atypical carcinoid. So that's why coding grade is so important. And it really does relate to clinical practice and how these patients are being treated in the real world. We want to make sure that we're using the most current version of the grade manual to code grade. Currently, that is 3.1. And when you open up the grade manual, you're going to see that those grade tables are organized both by schema ID, which is related to the AJCC schema, and there's a list in alphabetical order. So you can use either of those lists to find the appropriate table. But you have to know your primary site to be able to determine which table you're even using for grade. Because if you don't get the primary site correct, you are probably not going to get the grade correct. Sometimes all of the subsites within a primary site follow the same grade table, but sometimes they don't. And you can see that with some of our head and neck sites. For instance, if you only have positive cervical lymph nodes and you don't know where the primary site is, that defaults to grade table 98. Whereas if you do know that the tumor originated in the gum, for instance, you would be directed to use grade table 01. So code your primary site and use that to determine which table you're looking at. Here are some general principles as you are using the grade manual, because remember, if there are no site-specific instructions that are different from those general instructions, then the general instructions still apply. And it's only when we have specific site-specific instructions that are different from those general instructions that the site-specific instructions would take priority. So we do not code grade based on metastatic tumor or recurrence, because that grade is going to be different than if they had actually assessed the primary tumor. If primary site is unknown, then grade is going to get coded to 9 for grade clinical or pathological. If you are given a range, you're going to code to the higher grade within that range. So if it's moderately to poorly differentiated, then you're going to code to moderately differentiated. Here's another general tip for using the grade manual. If none of the specified grades are from the recommended AJCC grade system or schema, record the highest grade per applicable alternate categories for that site. If a grade is given for an in situ tumor, code it. We don't code grade for dysplasia, such as high-grade dysplasia, which was one of my examples earlier. Another principle that we use when we're talking about grade is that we have a priority order. Per the general section of the grade manual, if there is a discrepancy within that pathology report, our first priority order is that synoptic report, including the CAP protocols, then the pathology report, then the final diagnosis, and then a physician's statement of what that grade is. So when there's a discrepancy, we should be using the grade manual and the priority order in the grade manual to determine what grade we should code. And then, of course, as I've mentioned, we code clinical grade based on information prior to neoadjuvant therapy, because neoadjuvant therapy will change the grade. We do have some generic grade categories. Those are your A through D codes, and those generic grade categories are used for AJCC staging schemas where the preferred grading system is not available. So if we have a breast case and we don't have a Nottingham score, then we may default to some of those generic grade categories. Those generic grade categories are also used for AJCC staging systems where there is no recommended grade table, and I've given you some examples of that on my slide, or for primary sites without an AJCC applicable staging system, such as trachea. And then those are your generic codes, how we would have coded them before 2018 versus how we code them now with the new grade manual. So use those generic codes as applicable. Here's a little bit more about grade clinical. And this is one of those fields that cannot be blank. So we can't leave that field blank. So we have to use 9 if that grade is unknown. If there's only one grade available and it can't be determined if it's clinical or pathological, we are told in the grade manual to assume that it is grade clinical and code appropriately per the grade clinical categories for that site. And then we would code unknown for grade pathological. We're supposed to assign the highest grade from the primary tumor assessed during the clinical time frame. So if they do 2 different biopsies, we would use the highest grade from those 2 biopsies. If there are multiple tumors with different grades abstracted as one primary, we would also use the highest grade. And then there is an unknown code we would use when indicated, such as when we don't have a grade for the primary site or from that primary tumor, when they don't do a clinical workup. So these would be your patients that are actually diagnosed on surgical resection for another cancer perhaps, or for a benign condition, or we would use that unknown code when that grade is checked not applicable on the CAP protocol. Here's grade pathological, and that includes the grade that is given on that surgical resection pathology report. And that tumor must meet the surgical resection requirements for grade pathological. Grade pathological may include information collected during the clinical time period. So if the grade on the biopsy is higher than the grade on the surgical resection, we would use that higher grade even though it was collected under the clinical time period to code grade pathological. And then again, we have an unknown code when that patient didn't have surgery or when that patient had neoadjuvant therapy prior to resection. We would have to code grade pathological to 9 because, again, like grade clinical, we can't leave it blank. When this is a clinical diagnosis only, or when that grade is checked not applicable on the CAP protocols. So use that code 9 when you need to. Here's that derived summary grade 2018 data item, and it allows for comparison from previous years at the central registry level. It's an algorithm, like I mentioned. It allows researchers to analyze grade over time, and it is derived from those grade clinical and grade pathological data items. So that's where your central registry is going to go to make sure that that derived summary grade field is filled out correctly. So here is an example of using the grade manual to code a breast case. I just wanted to go over grade for breast cancer before we actually look at our example case. And for breast, we use the Bloom-Richardson or Nottingham score for grade. And there are those 3 factors that pathologists look at, and each one of those is given a score from 1 to 3. And I've defined them on my slide. Those are glandular or tubular differentiation, which looks at what percentage of that tumor forms distinct glands. Remember, forming distinct glands and looking like normal breast tissue is a good thing. Nuclear pleomorphism, which looks at within that breast tumor, are all of those tumor cells looking similar to each other, or are there a bunch of different weird looking cells? That's going to determine how nuclear pleomorphism is coded. And then there's the mitotic rate, which is how quickly are those tumor cells dividing. So for breast, we would use table 12. And again, we know that grade clinical cannot be blank. And 1 is going to be more favorable, 3 is going to be more unfavorable in those 3 categories that I went over in the previous slide. So the higher the score, the likelihood that that patient's outcome is going to be worse. It's unfavorable criteria if that score is higher. And each of those features is added up, and that gives you your total Bloom-Richardson score for those categories. A combined score of 3 to 5 points is designated as grade 1, which is going to be more favorable, and a combined score of 6 to 7 is going to be grade 2, and 8 to 9 is going to be your grade 3 for breast. Don't calculate that score unless all 3 components are available. So if they don't give you the Nottingham or Bloom-Richardson score and you only have 2 of those 3 elements, you cannot calculate the Bloom-Richardson score, and you're going to have to code 9 for grade clinical. All invasive breast carcinomas should be assigned a histologic grade, and that's going to be on the path report. We have to take grade from a pathology report, and that pathology should be looking at the primary tumor, not a metastatic site. There are some alternate names for Bloom-Richardson. I do see that comment in the chat. So it's also called Nottingham, Elston-Ellis, which I've sometimes seen on pathology reports. Nottingham, as I've said, there are some other names that they'll use, but those are just a few, and they all refer to the same score that you would use to code breast cases. So if you see those, you'll know that that's another name for Bloom-Richardson, and that you can use that score to code grade clinical and grade pathological. So here's the table, and you've got your 1, 2, or 3, which is going to take priority over your more generic codes. And you'll notice that they do give us the option of L, M, and H, but those are only applicable grades for in situ tumors. So if that breast tumor is invasive, we should only be using 1, 2, or 3 as our codes. Or if we really don't have that, then we can look at the situations that I listed on the earlier slide and default to those generic grade codes of well, moderately, poorly, or undifferentiated. But we really want to have that Nottingham or Scarf Bloom-Richardson, or any of the other terms. Elston-Ellis is another one for those breast cases. And then it's really the same for pathological. We have those same options. So let's look at a real case. A patient presents for an axillary lymph node biopsy. They do a workup, but no breast tissue was identified on imaging or on physical exam, no breast tumor rather. They do biopsy the lymph nodes, and 3 out of 4 axillary nodes are positive. These nodes are described as moderately differentiated with a high mitotic rate, and the referring physician indicates that the lymph nodes have metastases that are consistent with a breast primary. And this is a real case. I've just de-identified it. So how would we code grade clinical? Well, we can use that description of moderately differentiated to code grade clinical based on the pathology from the nodal metastasis. It is an exception that is specifically listed on the grade clinical section of the breast tables. So we can code it to B because that's the only information that we have for this particular tumor, and it meets one of those categories of exception. So that's how we can code that. Here's our second case. A patient notes a lump in the upper outer quarter of her right breast, measuring approximately 2 centimeters on physical exam. Mammogram and breast MRI are inconclusive. She proceeds to have a lumpectomy. The pathology report from the lumpectomy confirms that this is an invasive ductal carcinoma with a Nottingham score of 8, and the elements are glandular differentiation is 3, nuclear pleomorphism is 2, and mitotic rate is 3. So if we add that all up, we get an 8. And how would we code grade clinical for this case? Well, this patient was diagnosed on lumpectomy, and grade clinical cannot be blank, so we would code it to 9 or unknown, and we would use that information to code grade pathological. But we're just talking about grade clinical at this point, so we would code grade clinical to 9. Here's grade pathological, and a lot of this is information that is carried over from clinical. We've got a priority order, so those codes of 1 through 3 take priority over our generic codes. And remember that those low, middle, and high LMH codes are only for in situ tumors. We should be trying to assign a histologic grade for all invasive breast carcinomas. And there's the exception that I was mentioning for that first case that we looked at clinical grade. It's on the clinical grade slide as well. But that grade from nodal tissue may be used only when there was never any evidence of the primary tumor. Then we can use the information from the nodal tissue to code grade pathological. So here's your table again. It's basically the same as the one that we looked at for clinical. Don't forget to take a look at your notes as well. because there's some good information in the notes on the grade tables. So here's a patient. Here's just a couple of examples. Here's a little pop quiz. A patient is diagnosed with locally advanced breast cancer. They decide to do radiation treatment first to make that patient a surgical candidate. And then after radiation, the patient responded successfully and they were determined to be a surgical candidate. And they proceeded to a left mastectomy with immediate reconstruction. And that pathology showed invasive ductal carcinoma with a score of 8. How do we code grade pathological? Well, this patient received neoadjuvant radiation. So we would code grade pathological to 9 in this case. We can use that information to code post-therapy grade if we are working for a facility where that is collected, but we cannot use that information to code grade pathological because that is from tissue that was examined after neoadjuvant treatment. So we would have to code it to 9 because it cannot be left blank. Here's another example for you. This is a right breast tumor. It was biopsied. It's invasive ductal and lobular carcinoma, intermediate grade, glandular differentiation 3, nuclear pleomorphism 1, mitotic rate 2. And then this patient went on to have a partial mastectomy, which was consistent with invasive ductal and lobular carcinoma, and assigned a Bloom-Richardson grade of 1. So how do we code this case? Well, we can consider the information from the biopsy along with the information from the resection. So we can add up, because we have all 3 elements, we have tubular differentiation, nuclear pleomorphism, and mitotic rate, and that gives us a Nottingham grade of 2. And it's higher than the grade from the partial mastectomy. So we would use that to code our grade pathological. I did want to take a look, since we have a few more minutes, at some of the forum posts, because grade gets complicated and there are lots of interesting questions that get asked in that cancer forum section on grade, and I thought we'd just take a look at a few of them. So here's one. This registrar asked about head and neck schemas, and they specifically asked about those scenarios where we have positive cervical lymph nodes and an unknown primary. So should we be recording the grade from a lymph node in those cases, since we don't know what the exact primary site is? And there is a grade table. It tells us that that scenario uses grade table 98. Well, SEER answered that. Here's that section of the grade manual. And SEER said, no, you should be recording 9 as the grade in those situations. Just because there's a grade table doesn't mean that that particular case meets the criteria to be assigned grade. So I thought that was interesting as I was going through looking for what are people asking about when it comes to grade. Here's one having to do with bone and soft tissue schemas, and I've given you the dates of those posts. This was asked in 2021 and again in 2024, and the answer is going to be the same. This has to do with scenarios. The first one is a well-differentiated liposarcoma, no additional information, that patient had no resection. Is there a default grade for well-differentiated liposarcoma, or should that be coded to unknown grade? And then the second one is asking as well about well-differentiated liposarcoma / atypical lipomatous tumor. And they apparently did their homework as well and said that some posts on the forums indicated that that would get coded to 1, where others would indicate that it would be A or well differentiated. So SEER talked to their expert pathologists, and this would be a situation where grade 1 would be coded. And of course, in the first one, there was no surgical resection, so grade pathological would be coded to 9. And this just goes to show you that sometimes it does get more complex and that sometimes the pathologist can tell. Brain is another one where I see this frequently, where there's an automatic, if it's this type of tumor, the WHO grade equals X. So we can code based on what that histology is. And well-differentiated liposarcoma is another example where, because of the histology, there is that correlation to a grade of 1. So I thought that was interesting as well. Speaking of brain, This is a question about a case where the cranial meninges were resected and, well, the tumor was resected, and it came back as a meningioma with chordoid features. And there's a comment from the pathology report, which tells us that because of the architecture of this particular tumor, it does not meet the pathological criteria for what would be classified as a WHO grade 2 of tumor. And the registrar said, unsure if it should be coded to 9 as the pathologist did not assign a grade, or if the default grade of 1 would still apply. And as they note, 2 is not a consideration because that pathologist has ruled out meeting the criteria of a WHO grade 2 tumor. And SEER came back and said, assuming this is a benign tumor because there's nothing in the pathology report that indicates malignant, the pathologist ruled out grade 2, so the only grade available based on that schema is 1. So these are some scenarios where we can make some connections and code grade even when that grade is not explicitly stated on the pathology report. And I included that table so you can see what our options are. And the reason why 3 or 4 wouldn't be an option in this case is that a WHO grade 3 and a WHO grade 4 are assigned to malignant tumors. So if this tumor is benign, because it's not stated to be a malignant meningioma, then the only possible grades for a benign meningioma are 1 or 2. And if it's not 2, then by default, it has to be a 1. This is one that the forums asked about GYN cases. This patient had a bilateral salpingo-oophorectomy, and the path came back as mucinous adenocarcinoma, stated to be high grade on the pathology report. The physician stated grade 3, and this registrar quoted the general instructions in the grade manual and the priority order. So they're looking in the right place for this one. And they're asking, can that physician statement be used to code to a grade 3 in this scenario? And the answer is, it depends on the histology. We would need to know the histology because if it meets one of these histologies, if it's an immature teratoma or a serous carcinoma, then we are to use codes L, H, or 9. And they give us the specific histologies that would apply to. And then if it's not one of those named histologies, then it would get a code of 1 to 3. And if the grade isn't documented, it would get coded to 9. So this was a good example of why it's important to code that histology correctly to be able to code grade. And here's the note that SEER's response is referring to. One more example from the forums, since we're still good on time. This is from a 2023 PATH report of a breast case. Patient has DCIS, and then they do a lumpectomy, and there's microinvasive carcinoma associated with DCIS. So there's in situ plus microinvasive carcinoma. The DCIS was extensive, and we are given a grade for that DCIS. And it talks about how even in the comment it mentions that the slides showed only DCIS, but in some of the deeper sections, they do see a focus of microinvasive carcinoma. And the registrar was asking, what should the correct grade pathologic be in this case? And that was the registrar's understanding was correct. It would be a 9 because there's in situ and invasive. Even though it's only microinvasive, that's not in situ. So the invasive always takes priority, and you would code the behavior to 3 because of that microinvasive. And even though it's just a focus of microinvasive, that's enough to say that there's at least some invasive qualities to this particular tumor. And here's the note from the general section that confirms the answer that SEER gave. They say if there are both in situ and invasive components, code only the grade for the invasive portion, even if the grade is unknown. So this is one of those examples of we have the information from the in situ tumor, we just can't use that to code the grade. So let's do a little bit more practice. And specifically, I wanted to focus on breast cases, We've already talked about Bloom-Richardson or Nottingham score and how that's used to code, so I'm not going to repeat that. Here's another breast case for us to look at. How would we code grade clinical and grade pathological in this instance? We've got a biopsy that confirms invasive ductal carcinoma, grade 1 with DCIS present, and we've got a lumpectomy with a sentinel lymph node biopsy, and that had invasive ductal carcinoma grade 1. DCIS was present, lymph nodes were all negative, and so the grade clinical would be a 1 because we just have that biopsy and they did biopsy the primary site, and the grade pathological would also be a 1. This is pretty straightforward because I wanted to give you some straightforward examples that you might be seeing as well. Here's our second practice case. We have a right breast tumor. They do a core biopsy. There's invasive ductal carcinoma with lobular features. We've got a Nottingham score of 3 of 9, and there was some tumor necrosis present, no lymphovascular involvement. Then they go on to have a lumpectomy, just like the first case. Invasive ductal carcinoma, Nottingham score of 6 out of 9. There is DCIS present, no known neoadjuvant treatment. We know that's important for being able to code grade pathological, no extension, and lymphovascular involvement was present. So grade clinical is a 1 because if we look at our grade tables, a Nottingham score of 3 gets associated with a grade 1. The grade pathological is going to be 2. So even though we don't have the pathologist stating what that Nottingham score is associated with grade-wise, we can look at the table and say we have a Nottingham score. We can code grade based on that Nottingham score. So that is how I would code grade clinical and grade pathological for that tumor. Here's our third practice case. Patient has a lumpectomy of the left breast with DCIS, nuclear grade of 2. And then they do a mastectomy with flap reconstruction. There's DCIS, measuring 25 millimeters, and a nuclear grade of 2. And it's confirmed to be PTIS. So this is all in situ. Grade clinical is 9 because the lumpectomy would qualify as pathological grade. And then we have 2 different pathological procedures that we have tissue from. So we're going to code the highest grade from either of those procedures. And that's why we would code grade pathological to 2. Here's another case. Left breast biopsy at 2 o'clock, 4 to 5 centimeters from the nipple, grade 3 invasive ductal carcinoma, and then the patient has a partial mastectomy with high-grade invasive ductal carcinoma. Lymphovascular invasion was present, negative margins. Grade clinical is going to be 3 because we do have a grade, and that is likely taken from that Nottingham score. Grade pathological is going to be a 9 in this case because we can't use that high grade. And here is case 5, and I believe this is the last case that we're going to be looking at this morning. Right breast biopsy, 9 centimeters from the nipple, invasive pleomorphic lobular carcinoma, grade 3, and then they do a segmental mastectomy. There's no residual invasive carcinoma, and a physician's statement of complete remission. So grade clinical gets coded to 3. That's pretty straightforward, taken from the biopsy. Grade pathological is 9 because there was no residual invasive carcinoma on that pathology report. So those are just some examples for you on how to code grade. Let's see. Oh, yep, we've just got 1 minute left. So I've got one more practice case that you can look at. I've got the answers on the slides that you should have been sent before this workshop. And let's see if there are any questions related to grade. I don't see anything specifically related to this presentation, so I will go ahead and mute myself, and we're going to do some musical chairs here, and we'll be right back with Michelle's presentation on what we're doing at the state from a QA perspective. So I'm looking forward to hearing what she has to say.
Hey guys, quick mic check. Can everyone hear me okay? Wonderful. Okay. All right. Well, you guys all know me, and I'm debating if I want to turn the video on just to say hi. I guess so. Hold on. Hi and bye. All right. So I'm Michelle. I'm the QA manager. You guys know I've been around since 2018. I've done all sorts of things, and I do these types of presentations every year. Let's get into it. Oh, that doesn't work. Hold on. I'm going to do it this way. All right, so let's go over what my objectives are today. One big thing I want to talk about with you guys is our ACR edits. I'm going to go over what's going on for V24, and then I'm going to give you guys a little bit of a preview for V25. It wouldn't be a QA presentation if I didn't talk about death clearance, so we're going to talk about that for a nice little decent portion of the presentation, and then we're going to talk a little bit about hospital resubmission files. So again, if you guys have any questions, pop them in the chat or Q&A, and we'll go over everything at the end of the presentation. Okay, so first things first, ACR edits. So I know most of you are experienced registrars, but there might be some newbies in here today. So kind of wanted to talk a little bit about, what are edits and what do they do? So basically edits are kind of just an automated method to check your abstract for completeness and just to make sure that there's consistency between what you're coding. So basically, did you code everything that was required, and did what you coded make sense? So it just kind of applies logic in your coded abstract, okay? So I gave a couple of examples. A really good one is edits that check to make sure that you're coding something once it's required. So summary stage 2018 is coded on all 2018 forward cases. So the logic in the edit is if the diagnosis year is 2018 plus, summary stage cannot be blank. Same thing for, say, an edit that checks for coding consistency between dates. So looking at date of diagnosis and date of last contact. So the logic could be date of last contact cannot be before date of diagnosis. Just simple stuff like that. Simple stuff. All right, so let's talk a little bit about our state-specific edits. So full disclosure, those edits are written by standard setters. So they're written by the CDC, they're written by NACER, SEER, COC. We do not currently write any of those edits that are in our edit set. We do issue a new version for our hospitals every year of our edits, and that edit set gets updated with every new software version. So you had one for V23, V24, you'll have one for V25. Sometimes you'll have several versions, but that's kind of the new norm these days. We call the file our state-specific edits meta file. So meta file just kind of means it has all of those edits and then a bunch of extra stuff like these tables that the edits reference and things like that. And I'm going to kind of go over that too in a little bit here. So we post that edit set, that meta file, onto what's called the edits clearinghouse on the NACER website. And then we also post it to our own website as well. So we also create this huge edits description document. And yes, I do think it is 1,600 pages of fun, but basically what that document does is it lists every single edit in that meta file. It lists the logic and all of the data items that the edit looks at. And then it'll also give you some notes about any changes to that edit, because some of these edits have existed for a very, very long time and they get updated. So that document is also on our website. If you ever are just feeling squirrely and you want to go download it, it is absolutely available for you. So right now, because ACR is currently in V24, our software is V24. Our current edits meta file is that V24A1 meta file that I have listed right there. And then I also have our website if you guys want to go directly to it. So there's not a whole lot going on for V24 as far as changes. The biggest things that I want to draw your attention to are that we do have some new edits to make sure that we're coding new required data items. So the big ones are the two SSDIs that Juliet mentioned in her presentation, that brain primary tumor location SSDI, and then the P16 needs to be coded for vulva for 2024 forward, okay? There is also, in that big old meta file, a new resource, and that resource is called Cancer Path Chart. So that's checking for site histology coding validity for 2024 forward. And I also made sure to put in here, I don't want anyone to think that they're required to go back to their cases coded prior to 2024 and apply these new standards. That's not required. And then I also wanted to talk to you guys about an edit issue that we've been notified of by our standard setters, and just kind of tell you guys what to do if you incur that, or you encounter that issue with that edit. Okay. All right. So as Juliet said, I'm going to talk a little bit about cancer path chart, and I like to include hyperlinks in my presentation, so please go ahead and go check it out. That link there at the top is actually going to bring you to the facts section of the ACR site for cancer path chart, and it's actually really informative. They have videos, trainings, all kinds of fun business there. So I'm giving you the definition of what cancer path chart is. In layman's terms, it's just a new standard for tumor site and morphology combinations. They have what they're calling an implementation timeline, so they're not just completely rolling out path chart 2024 forward. It's actually not going to be completely rolled out till 2026 is what they're saying. So we'll go over that in a second. There is also an active online search tool called CPC Search, and we're going to look at that a little bit too. It's a lot of fun. But basically all cancer path chart is, it's just a new way of verifying that different site and morphology combinations are valid or not. So the big difference between path chart and what we do use formally, which was the ACR validation list, is there's a new designation called impossible. So that new designation is really going to come into play when we talk about edits that point towards this cancer path chart for 2024 forward. Okay, so we'll get into that. All right, so I was mentioning that little implementation guideline thing that they had talked about. This is it. So basically their goal is to switch this entire site histology validation business to cancer path chart from the ACR site and histology validation list that we've been using for years and years and years. All right, so I included the link to find this as well. This is the cancer path chart search tool. So the real cool thing about this is that, and I have some little red arrows to kind of direct you where to look, is that you can search either by term or by code. So me, personally, I like to use codes. I don't like to take all that time typing out words. So you can just basically enter in your primary site and your histology code. You hit the search button and it does a little thinking, and it'll give you results. So basically, if that site and histology combination has been reviewed for cancer path chart, it'll issue a designation. So as you can see, C220 and 8160 are impossible. So, and I don't want to butcher cholangiocarcinoma. I always say it wrong every single time, but that is impossible to occur in the liver. You should probably be coding that to C22.1, intrahepatic bile duct. Okay, and just because I'm not mean, let me give you guys an example of something that is valid. So I popped in sigmoid and adenocarcinoma NOS, and as you can see, it returns that value of valid for that particular site and histology combination. So when you're using that search tool, what are you searching? Well, you're searching a big old table, and that's essentially what a path chart is. So again, you see a link there at the top of your screen. You guys can go and check all of these things out if you are so inclined to do so. This is a huge thing that you can download and look at. They've got versions for 2024. They've got versions for 2025. Again, I used my handy dandy red arrows to tell you what you should be looking at. It's basically, you can see cancer site, histology, behavior, and then that status is that designation. And then you can actually see in the table below that I kind of gave you the legend of definitions about how they categorize those things and what those things mean. But essentially, it's just a big Excel document that has a whole bunch of combinations. All right. So you're like, Michelle, why are you telling all of this to us? We don't, because starting with V24, there is an edit, and I've got it listed in the slide there, that actually references path chart for 2024 forward. So there are going to be some histology and primary site combinations that you are used to being able to override with an override code that you can no longer do so. And I gave you a good example of one with C220 and 8160. That is now considered an impossible combination. So that means if you try to code that for 2024 forward, you'll get an edit, and you cannot clear the edit by checking an override flag. All right, let's talk about this one. So it was brought to our attention actually by a software vendor that there is an issue with edit number 6774. Now, this edit is actually an important edit because it checks the new surgery codes that we're coding for 2023 against primary site. So basically what the issue is that the table that this edit looks at is actually missing 3 codes for breast, and I've got them listed there below. So basically, because those codes are missing, if you code that surgery code for breast, the edit triggers. Now, I want to make it very clear, if you are coding the correct surgery code, please do not change the surgery code to pass the edit. So in the rare instance that this edit populates for primary site breast for these particular surgeries, reach out to us. And actually, when I say us, I mean me. Just email me. But we will tell you what to do. So when NACER found out about this, they actually did a study, and they said that these codes are used so rarely that they didn't want to issue a corrected edit and a new meta file to fix it. So that being said, it's there, and there's nothing we can do about it. Okay, so we just need to work with you guys if you encounter this problem. Now, they corrected it for V25, I know, because I went in there and I checked. So these codes are in the table. It should reference them just fine for V25. It's just V24. We're going to have a problem with this particular edit. Okay, so what's coming up? So we've actually already got a V25 edits meta file, and it is on that edits clearinghouse website for your vendors. Software vendors have been requesting that we get these kinds of things to them earlier and earlier. So we're doing our best to make sure that they have everything they need to provide you guys with your updates in a timely manner. I will say this, that version that is posted to the clearinghouse will not be put on our website because we know that by the time you guys are ready to convert to V25, we're probably going to have a new version. That newer version on the website for you guys, probably like beginning of 2025, like January, February, not sure. I will say this, there are a few new edits in it, nothing too horrible. Big ones are the 2 new SSDIs that Juliet mentioned for 2025. So there are edits in there just making sure that you are coding those new SSDIs for 2025 plus. Also, just a heads up that path chart edit N7040 is going to start pointing to additional site and histology combinations. So I gave you a little list there of the sites that they reviewed for 2025. And the biggest one I want to give you guys a heads up on is that they don't want you coding the urothelial cell carcinomas to kidney C64.9. They are now designating that as an impossible combination. So, and you would need to go back to your case and make sure, but most likely a lot of those are going to actually be coded to the renal pelvis, which is C65.9. So giving you a heads up about that. So starting in 2025, if you try to code an 8120 or any of the subtypes to kidney, it's going to give you that edit error that you cannot get rid of with an override. Okay. So now it's time for my favorite topic of the day, and that's death clearance. I feel like I talk about death clearance a lot lately, actually. And before I get too far into it, I just want to give a big thank you to all of our hospitals who worked on their reports very diligently and got them back to us on time and got us all of those cases. I want to give a big shout out to Dana. She's not here right now, but she took on a lot of Keith's old responsibilities in doing the initial linkages, which was a lot of work. And just everybody else here at the Central Registry too, who has really stepped up and helped with this new process. All right. So again, if there's anyone new in the house who is curious, here's the definition from the actual death clearance manual of what death clearance is. Now, side note, and I don't know if she's popped back on, but Georgia actually helped write this. She is cited as an author for this manual. So if you're ever really curious, she contributed. But it's a very interesting update, very detailed, very good manual. And I think I have a link to it in a later slide if you guys are curious, you want to download it. But basically, they define the process of death clearance as matching those registered deaths in a population. So when we say population, we mean state of Arizona, for two purposes. So we want to update that death information for anyone who has passed who is in our registry. And two, we want to potentially identify any cases with reportable conditions that we missed and follow back and try to create an incidence case from that information. All right. So what are our requirements? What are we required to do? Well, we are required to perform a linkage of our central registry database with our official mortality file from vital records. And we are required to do that at least once per year. We are required to update our registry record with any death or other relevant information from that mortality file for each patient in our database that matches in that linkage. Now, the ones that don't match and meet the following criteria, we're required to perform follow back. So I'm giving you the general criteria of who we are required to follow back on. So an Arizona resident who died in Arizona, and let's say their death certificate has some sort of reportable condition coding as the underlying cause of death. So some sort of cancer diagnosis as an underlying cause of death. Now, they did not match at a patient level in our database through this linkage with vital records. So we need to find out, did that patient have cancer? If so, is Arizona responsible for reporting that cancer? I'm actually going to take a second to drink some water here. I'm talking too much. All right. So what is the purpose of death clearance follow back? The goal of death clearance follow back is to get as much information from a clinical source. Now, mind you, the death certificate is not a clinical source. So we either want to find enough information about that patient to complete an actual case, or bare minimum enough to code an incidence case for that deceased patient, or we want to be able to find enough information to determine that that patient's condition actually was not reportable. Another question is, what happens to these death clearance cases that either don't have follow back completed, or maybe the follow back is insufficient? Well, those go into our database as a death clearance only, or a DCO case. So unfortunately, what that means is the only documentation that we have of that patient's cancer is whatever minimal information was in the death certificate. And our goal as the central registry is to have as few DCOs as possible. And you're like, well, why does that matter? Well, our DCO rate impacts our certification as a central registry. So I stole a whole bunch of this from Georgia's presentation from session 1. So there's our little handy dandy chart of our NACER certifications for the entire United States and Canada. As you can see, I've got my little red arrow there pointing towards us. We're gold. And that means that 3% or less of our reported cancer cases were DCOs. Now, silver, the threshold's a little bit higher, it's 5%. So the problem with DCO cases is that they contain very little information. They've got NOS codes. They're not considered to be reliable or complete data. So basically what that means is if we have a high number of DCOs in our database, that impacts our overall data quality, and that's a problem. That's why they have these percentage limits on each state. So in case you guys like math and statistics, that's how they calculate it. So, and as you can see, these are more graphs I stole from George's presentation, but our DCO rate, our death certificate only rate, since 2018 has been gold. We've been able to keep it under 3%, and that is not an easy task. And I'm about to show you why. So longest, smallest font slide ever. I'm not going to read all this. I put a little joke in my notes to tell you guys it's just a quick 10-step process. This was our first year completing this process without an analyst, without a Keith. There's a lot to it. It is a lot of work. I kind of wanted to document this process, not only for myself because I'm learning, but for anybody out there in the hospital registry world who ever wondered what on earth, you know, we do with our time when we're working on death clearance, or maybe some new people within, you know, our central registry who might wonder why I'm like walking around half mad and tired all the time for like 6 months out of the year. This is why. So basically, we start with the linkage, the big linkage, and that's the linkage of our database to vital records. We're trying to start that as early as possible every year. So we use a product called Match Pro to do that linkage. So for diagnosis year 2022 in particular, from that linkage, we had about 10,000 matches. So that was an Arizona resident at diagnosis who died in 2022. We had about 2,400 what we consider non-matches. So I give you the criteria there. Arizona resident at time of death, died with a reportable condition listed on the death certificate in 2022. So what we did with those 10,000 matches is we updated our database with all that pertinent death info from the death certificate. And then those 2,400 non-matches went through an extensive follow back process. And I've listed that for you guys below. So, you know, we issued all of the reports that we require you guys to do. We review all of those death certificates manually for something called duration, which is, and I give an example. Sometimes on the death certificate with that cancer diagnosis, they'll give you a time frame. So for the example I have there, lung cancer, 3 months. So you're actually allowed to use that time frame to estimate the date of diagnosis. And in rare instances, you're able to estimate that date of diagnosis to a previous diagnosis year, which helps your current year's DCO rate, if that makes sense. Now, we also go through when we review for non-reportable terms. So I gave you an example of that. Like, let's say I look at the death certificate cause of death is lung cancer, but what I read in the text is possible lung cancer. So we're actually able to apply the same ambiguous terminology rules that we do for reportability to death certificate cases as well. So we could eliminate that as a case requiring follow back. Also, I've noticed a lot of death certificates coded to just skin cancer, NOS, and you go in and you find out that it was a basal or squamous. So you're able to eliminate those as reportable as well. So I give you some counts of how we kind of whittle down this number as we go. So remember, we started with 2,400. So there's additional linkages. We link it to your hospital discharge data and unfortunately send you another report. I'm sorry, but it does help us with this. We also go in and what we've been doing recently, and this has actually been very successful, we actually have access to, is it called Health Information Exchange, HIE, the portal, and it allows us to actually have access to some patient medical records. And so we actually use that to perform our own follow back. So while you guys are doing follow back within your systems, we're doing it too. So you can see there's all these little things that we do that whittle down. We also continuously relink the information that we have from those death certificate cases to our main system to look for new matches, because some things slip through the cracks and just end up being reported as a regular case from you guys. So the big thing I want to draw your attention to, and I've highlighted in yellow. So this year in particular, we started with 2,400 DCO cases and we ended with only 400. And it took a long time to get there and a lot of hard work on both sides, from you guys and from us. So I just, again, I want to just tell you guys how much I appreciate everything you do and how much you help with this. So it has been an eye-opener to be as involved in the process as I was this year. There was a lot of things that used to happen behind the scenes that I didn't touch that now I was very involved in. And so looking forward to 2025, there are some things I think that we can do to make the process better. I'm always open to feedback. If you guys have opinions on this too, feel free to share. But the big thing is, I think we're just going to do one death clearance report. So I'm going to figure out how to do it. I'm sure we can figure it out. We're going to combine the two reports into one. So you're going to get vital records information, and you're going to get hospital discharge data information in one report. So it'll still be one report per hospital system, and then each facility ID will have its own tab. And you know, the convenient thing will be there's going to be one report, one email, one deadline. I think this will make it a lot easier for everybody going forward. We're also going to try and start earlier. Goal is April right now. I'm not really sure if that's going to happen, but we're going to try. Another thing that we've noted, as far as when you guys submit your death clearance cases, we're just going to have you put them in the monthly submission. So I would just say, I'm going to give you a heads up, make sure that you are able to do that and make sure that all of those are included if they are new cases that need to be reported to us. But when we try to do the separate file, I know it caused you guys some different burden and issues, and we don't want to have you guys have to deal with that. So just part of your monthly submission is fine. And then this next one, actually, I talked to Ryan this morning, we might need to not do number 4. Goal is eventually, once we get you guys set up with Web Plus, if that is something that we could do, which is something she's going to talk about in the next session, to have reports submitted that way. But it's looking like we might still have to kind of juggle between the SFTP and secure email. So we'll figure that out, though. We'll figure that out. All right. So here's some light reading for you guys. So one book that I found very interesting and that I actually did start reading because I wanted to know what the rules were when they were actually coding cause of death is the Physician's Handbook on Medical Certification of Death. That is actually the link to the 2023 revision. It is very interesting, the rules that they follow and the different things that they are able to do that we need to be aware of when we're determining whether or not something is actually reportable or a true death clearance case that needs follow back. So it was a good read. And then if any of you guys want to see George's awesome work on the 2023 NACER death clearance manual, you can follow that link and get that as well. Okay, so lastly, let's talk about resubmissions. So for me to talk about resubmissions, I kind of need to talk to you guys a little bit about the difference between timeliness and completeness. And I am including one of Keith's awesome reports. So you guys have that for reference, because I know a lot of you are familiar with those and have seen those before. So when we refer to timeliness, what we're really asking is, was the case submitted according to our reporting requirements that are in our rules and regulations? So when we look at timeliness, we're looking at the date of discharge, we're looking at the date of first contact, and then we're looking at the date the case report was received or exported. And the time frame we're looking at is a calendar year. Whereas for completeness, what we're looking at is we're looking at your counts for prior diagnosis years, and we're trying to see if that case count for your facility is comparable to what's been submitted previously. Does it fall in line with what we anticipate your case count to be for that particular diagnosis year? So when we're talking about completeness, all we're looking at is date of diagnosis, and the time frame we're looking at is that diagnosis year. So why might we approach you for a resubmission file? So you all know that we track timeliness and completeness collectively for all of our reporting sources, and then we also track it specifically for each hospital system and facility ID. So here are a couple of examples of some scenarios where we might request a resubmission file. So let's say that for a particular diagnosis year, we're noticing case counts are low and they're not meeting certain benchmarks that we expect to see. We might request a resubmission file from you. Let's say overall, just our timeliness percentage is lower than normal for a given month and or year. The last two here are big examples. Let's say that you, as a registry, have communicated maybe some software issues, some database issues, staffing changes, basically anything that might have impacted timely and complete data from your registry, where we're probably going to request a resubmission. Conversely, let's say you come to us and you're concerned about your case counts. Let's say we've sent you one of those reports and you go, wait a minute, that doesn't look right. Well, usually the only way for us to resolve that is a resubmission. So it's basically, and I almost crossed off the word quick, because it's not quick, but it is a very efficient way for us to identify some cases that might not have been previously submitted and get those quote unquote missing cases into our system. So how will you know what cases to include in a resubmission file? Here's the truth. All you need to know is we will tell you. We will tell you exactly what we want you to resubmit. We'll give you the time frame and we'll tell you exactly what we're looking for. So with that time frame, again, it's going to be either by calendar year or diagnosis year. So an example of when we ask for a resubmission file for diagnosis year, we'll just say, hey, we want you to resubmit all your diagnosis year 2023 cases. So when we're asking that, we are asking for all of your complete reportable cases that are currently in your database with a diagnosis year of 2023, for example. Now, when I say complete, I mean, don't send us the suspense cases or the weird stuff. We want the stuff that should have already been sent to us for that particular diagnosis year. So, and I also want to make note of how you make sure you include all of those cases by diagnosis year will vary based on how your software works. And I have an example on a later slide about what I mean by that. So let's say we ask for a resubmission file by calendar year. What do we mean? So let's say example, we email you and say, hey, we need you to resubmit all cases completed from October through December of 2024. So when we ask that, what we want is all your reportable complete cases, regardless of diagnosis year, completed between 10/1/2024 and 12/31/2024. So when you would pull that resubmission file, you'd pull it kind of in a similar way to how you pull your monthly submission files, but you would use our specified date range. So I hope that makes sense. All right, so what do we do with your resubmission file? Short answer is we compare apples to apples and we give you feedback. So we're going to use the same criteria we gave you when you pulled that resubmission file. We're going to pull that whatever information we have from your facility from our database, and we're going to compare the two files. So I mentioned Match Pro in Death Clearance. Again, that's a linkage software that allows us to match these cases and find missing cases. So we can match those records based on a ton of predetermined identifiers. So name, date of birth, address, social security number. We can even get to the point where we can match it by primary site, date of diagnosis, whatever. So basically, when we do that with your resubmission file, we consider anything that doesn't match to be a missing case. So the cool thing about doing it this way is that those missed cases that are in your resubmission file, we add them to our database. So you don't have to submit anything further. We'll just put them in and we'll have all of those missing cases from you. Now, what we do on the tail end of it is we will create a patient listing report of those missing cases and provide it back to you. So what we hope you do with that report is take a look at those patients and try to determine why those cases didn't make their way to us originally. How did those cases get missed? All right. Again, another slide I'm not going to read fully. There's a lot of information here, but I just wanted to give you guys some tips and tricks about how to pull that file. And again, it all depends on whether we're asking for a diagnosis year or calendar year resubmission. The one example I wanted to talk to you about is when you pull by diagnosis year, and I don't really know about you guys, but our software, Rocky Mountain, has some quirks. So, you know, when we ask for a diagnosis year, you think January 1st to, you know, the end of December of that particular year. Well, for some reason, when you put in those dates, Rocky Mountain completely skips over any case that has an incomplete date. So I'm giving you an example. So when we do these things in Rocky Mountain, we actually set that range to be, and I gave you actually physically what we type. We set it to that kind of range. So we literally have to do spaces and then the year. And then for the maximum of the range, we have to fill with 9s in the year. And then it will include all of those partial date cases. So I guess my tip to you is your system quirky? And is that something you need to do as well? So that's just something to be wary of. When we ask you for a resubmission file, just make sure if your system's weird and does things like that, that you kind of make sure you get all of those cases to us and pull all the cases you're supposed to. As far as resubmission files by calendar year, I gave you some tips. We will tell you which data item we're going to pull our comparison file on. So you would just pull them using that same exact data item is what I would recommend. And since when you're pulling by, say, date case completed or date report, case report exported, since your software codes those dates, it should have a complete date there, so you shouldn't have to worry about that. Another quick tip, if someone else is pulling the file, let's say you're not the one doing it, just please make sure you tell them exactly what you need. So make sure you're telling them the parameters of what they need to be pulling so they pull it correctly for us. Also, just sending everything to us, unfortunately, it creates a lot of extra work. So I would ask when we request a resubmission, please only send us what we ask for. And then my last tip is just to be empowered. So ask your vendors how you run these types of queries if you don't already feel empowered to do this yourself, how to run these queries. Ask for training materials, ask for access. So I think it was session 1 when Juliet talked about how we actually, we had the brilliant idea to reach out to all of the software vendors and try and get some of these training materials for you. And we were told no. They don't want to provide that information to us, but they will provide it to you. So you have to ask. So I will say this, if you ask and they aren't very nice, please feel free to CC one of us and we will happily assist you in getting whatever you need. But all right, I think that's all I've got, guys. I see lots of chat stuff. Did I do okay? Or are we in bad shape? There you go. Thank you. Lots of questions. I don't want questions. All right, guys, hold on. I'm gonna go ahead and mute myself and then we will get back with the Q&A, okay? Be right back.
All right, guys, we're gonna do the Q&A. Just quick sound check. Can everyone hear me from this far away? Are we good? I'm getting confirmation from people in the room, but I want to make sure that people online can hear me as well. All right, how about now? I got a little feedback, hold on. Better, okay. All right. All right, so let's see. We are going to not, the first question I saw was, Deb, I saw your question real quick about, that, what was it? Data item 250. You're right. We haven't required that in a very long time. I don't know why they do this. They will just stop requiring a data item and let it sit there. And then they decide to retire it. So you're exactly right. You are required to code 252 and 254. We haven't required 250 for years. They finally just let it go. So that's all Juliet was saying, is that one's just getting retired finally, but we haven't required it in a long time. But yes, please continue to code 252 and 254 for birthplace. All right, let me scroll back up and read these other ones. Does the ACR get to choose additional edit fields to include in the meta files, or do they just get the standard setters version? Wait, hold on, let me pick up here. So the meta file that NACER distributes has several thousand edits in it. We get to pick and choose. So, for the most part, we try to adhere to whatever NPCR is requiring. We try not to include things on data items that we don't require. I will say this, our edit set is pretty robust. The only thing trying to think of what else to explain. I think that honestly, that's about it. Yeah, I don't know why my train of thought just completely left me. It's because I'm the one responsible for answering questions. So yeah, they basically, they create the edits we can pick and choose. And we try to put as many in there as possible, especially with a focus on newly required data items, so that you guys aren't inadvertently not coding things that are required for that diagnosis year. But yeah, the standard setter versions of edit meta files that they issue are usually substantially smaller, if that makes sense. Let's see, can cancer path chart be used in place of the ICD-03 Excel list, which is not user-friendly, or is it just, so I want to make sure that I make the distinction between what cancer path chart is and what the ICD-03 is. So cancer path chart, we're strictly talking about site histology validation. So the good old SEER site histology validation list that used to get put out every year, that's what cancer path chart is replacing. So you still need to use your ICD-03. And I don't know if you're talking about that Excel document that they've been spitting out instead of a new manual. Rose, is that what you're talking about? Because cancer path chart at this point in time is, no, it is not yet a replacement for that. It's not a replacement for that. I don't know what they're going to do with it in the future, but as of right now, think of it only in terms of, I agree, it is lousy. Well,
I know, I want a book. But yeah, so path chart, strictly site histology validation. Use it in the same way that you would use that SEER site and histology validation list, okay? All right, sorry, I gotta scroll back up here because I saw your other question. If you do all this work to get the death information, why can't the ACR send lists to everyone at the end of the process so that we can upload death information that we don't have without having to submit? Yeah, I know. I agree. This is something we've been talking about, and this is something that I need to talk with
I know you're gonna I appreciate that you keep asking. So I would love to be able to do this. Right now, logistically, we can't, but it is something that we continue to talk about. When we can figure out how to do it, and if we're allowed to do it, we will let you know. Trust me. And you're probably gonna ask me the same question next year. It's okay, but we'll work towards it, Rose. I promise. I swear. All right. Did I miss? Aha. All right, if we combine the death match list, can we please have a column that specifies vital stats versus DC? Deb, I'm not quite sure that specifies vital stats versus death clearance diagnosis. Uh-oh, my computer's battery saver's on. Deb, you know what? Will you do me a favor? Can you email me that question and you and I can go back and forth about that a little bit more so I can understand what you want exactly? Because we can work on that. Yeah, we can figure out what you guys want in that report that makes it easier and better for you. Does that make sense? I'm happy to see what we can do, okay? Did I get all the questions? I feel like I need more caffeine, guys. This has been one heck of a day. All right.
We just wanted to thank all of you for being here with us today. We appreciate it. We know your time is valuable. I posted the evaluation form for today's workshop in the chat, and I will be sending it out via email as well. We ask that you fill that out. We greatly appreciate it, and we look forward to hearing your feedback. We will join you again 1 week from today with the final session of this year's educational workshop. And enjoy the rest of your day.